Hi, hello, and welcome to our Family Medicine Top Tips and Tutorials. I'm Dr. Muller. I'm a family physician here at CMH, and we're quickly going to have a look about how we get our patients to target with our type 2 diabetics. So in one of our top tutorials on diagnosis, we talked about how we decide somebody's got diabetes, and now we want to get that HbA1c on target as discussed. So firstly, it's important to understand that we progressively introduce our different medicines. So we usually have the stepwise approach. And the biggest reason why we do that is because we're also concerned about side effects, and it also helps a patient to adjust to this increasing number of tablets that they're going to be on. But many of our patients will actually end up on insulin early on. And it's very helpful to understand that if you have a baseline HbA1c of more than 9%, that patient is definitely going to end up on at least two oral hypoglycemics. And not necessarily that you'll start them all at the same time, but you want to actually add in that glimepiride really early. And you can warn your patient and say, listen, you're definitely going to need two different tablets and get them to target as quickly as possible. But there are patients where you can actually even consider starting insulin right from scratch. And especially those patients with the higher HbA1cs and those patients who actually presented very sick. So if you've got somebody who's presented with a DKA for the first time or very, very high sugars already in a catabolic state, you can consider putting them straight on insulin. For some patients, that can be quite a shock if they haven't been aware of the diagnosis before, to go straight onto injectables. And if you do decide not to start them, then again, you want to try and get them to target very, very quickly. So we've mentioned earlier that one of the challenges with getting people to target is that quite often people use the HbA1c to adjust the medicines. But the problem is, if you do that, you're only going to be adjusting the medicines every 3 months. And what we want to do is, from the moment we start treatment, we want to try and get people on the amount of treatment they're going to need to be on target within 3 months, if possible. So we want to actually get them under control as quickly as possible. And it's been shown that the long-term complication rate is massively affected by how quickly you can get your patients to target early in the beginning. So we're just going to quickly talk through our only 2 oral hypoglycemics that we have available in the public sector. There's some very smart stuff available in private that we don't have access to, but Metformin is still a very good standard treatment in terms of managing our diabetics. Not only is it good in terms of the actual sugar control, but it's one of the few drugs that actually addresses insulin resistance, which is one of the major contributing factors for our patients. The challenge with metformin is that it's not so pleasant on the gut, and quite often patients, if you go in too quickly, they can develop diarrhea, and you therefore usually start slowly and build it up. And what we need to make sure is that we don't end up getting stuck on the lower dosages. So very simply, what we do is we'll start them on the 500 milligram once a day. If you've got quite a large patient, you can even start them on the 500 milligrams twice a day. And what we want to do is we're going to bring them back every 2 weeks, ideally. Sometimes for patients, that is a barrier to care, and you might have to do 4 weekly. But at each of those visits, they're going to come in. We're going to do when they arrive, we're going to do a sugar on arrival. We're going to ask them to always be fasting when they arrive at the clinic. And if that base sugar is still over 7, you increase your dosing immediately. So you're pretty much going to go from 500 milligrams a day. 2 weeks later, 500 milligrams BD. 2 weeks later, if the sugar is still over 7, you're going up to 1 gram BD. 1 gram BD is pretty much the best you're going to get in terms of HbA1c management. If you have patients who are still not controlled, one can consider the 850 milligrams TDS, but that's no longer going to have much of an effect on your HbA1c. It does, however, still have quite a good effect on your insulin resistance. And so for obese patients, it might be worthwhile to go up to the higher dose. But by the time you've reached 1 gram BD and you're not under control, you're going to need to add in a sulfonylurea. So your next step will be to add in your sulfonylurea. Private sector's got a few more options. In our setting in the public sector, the only drug you're going to consider using is glimepiride. Please note that we do no longer use glibenclamide. It's one of the older sulfonylureas and has various issues. And therefore, if you see patients on glibenclamide, please transfer them over to glimepiride. The glimepiride dosing comes from a 1 milligram tablet, and again, we're introducing it slowly, mainly to see that the patient is tolerating it in terms of hypoglycemia. But also to note that once you get over 4 milligrams, it doesn't actually have a dramatic effect on your HbA1c, and there's not therefore that much benefit in going higher. You're not going to have huge benefit in terms of sugar control, and you have a high potential of side effects. So you'll start with 1 milligram, usually after 2 weeks, sugar still over 7, you can go up to 2 milligrams. If the sugar is still over 7, I would go straight up to the 4 milligrams. And at this stage, if the patient is not controlled on the 1 gram BD of the metformin and the 4 milligrams of glimepiride, you're now actually going to have to start looking at introducing your insulin, which will be in our next tutorial. It's important to realize that a lot of patients will need insulin, especially those, as we've mentioned, that starts off with higher HbA1cs. And we need to prepare our patients for that from the moment we start them on treatment. And we need to build insulin up as this great medicine, very easy to administer. We'll be able to train you up not to worry, and sort of start preparing our patients psychologically for being able to go onto the injectables when it is eventually needed.